So I'll call over the meeting of the Pajaro Valley Healthcare District Hospital Corporation, also known as Washington Community Hospital. Before we take a roll call, I want to make an announcement that Director Phil has requested an excused absence for our May meeting, and she is traveling out of the country. I'd like to make a motion that Director Phil's absence be excused. So moved. Second.
Who wants second? Is that for both Gallagher and Hopkins?
I'm happy to defer.
Okay. Thank you. I'll take roll on this item. Director Cox?
Yes.
Director Gallagher?
Yes.
Director Pimentel?
Yes.
Director Hughes?
Yes. Okay, Rosie, whenever we're ready, a roll call, please.
Yes. Director Cox?
Here.
Director Gallagher?
Yes.
Director Pimentel?
Yes.
Director Hughes?
Here. We have nothing to report out of today's closed session, and I'll go to staff for any agenda modifications for consideration for today's meeting. Seeing none, I'll move on to the public comment for matters not on tonight's agenda. Rosie, any raised hands for folks looking to speak online? No hands raised. Anyone wishing to speak? Seeing no raised hands, I'll close down the public comment for matters not on the agenda and move on to comments from board members. Any comments from the board?
Yeah,
Please.
thank you, Chair. Collecting my thoughts, I'll admit I've been in denial of this topic for a little while, and I just want to take a moment and acknowledge everybody's hero and good friend, Matt Coe, for the incredible career, legacy, and dedication and passion and commitment he's given to this entire community, not just this hospital organization. I want to make a joke about this, and I do have a regret in that I think my brother was closer to you than I was. And I'm really jealous of that right now, way back in the day in high school. But you know, you stood out way back when to me, and I consider it a privilege to have crossed your path professionally as much as we've been able to, and things we've gotten to joyfully work together on in a really, really crazy different space. It's just reminded me of how rare and unique you are. And you know, it's also a wonderful example of this community and who they are and we are. So I just thank you for your commitment. I thank you for your passion. I thank you for your friendship. I thank you for your intelligence. I thank you for the first time you walked me around this hospital and you gave me, you know, a lot of patience that day, and I was asking a lot of crazy questions. And it was also impressive to see not just one, but everybody take a moment and make eye contact and acknowledge you, and you acknowledge them. And it just demonstrated how much you've meant to everybody personally. And I think that's your legacy. And I don't want this ever to be goodbye. So it's just, for me, it's a see you soon, see you later moment. And I just want to acknowledge and appreciate you and everything you've done for our community in this hospital.
Thank you, Marcus. Two quick things. One is the jump shot that was memorable, right?
Yeah. Well, it was given to me a few times.
Secondly, the comment about unique is great, because I don't think I can handle another one myself.
Yeah.
So, thank you, appreciate it.
Thank you, Marcus. Any other comments from board members? I let Marcus have that one. But thank you, Matt, for everything. I know we got a couple more meetings to get through and whatnot, but thank you. If there's no other comments, I'll move us on to the consent calendar, and I believe we have two items tonight on the consent calendar. Item number one is minutes approval for our April 30th, 2025 meeting. And item number two is an agreement with our Radiology Diagnostic Services Corporation Incorporated. Any questions for staff about either of these two items before I go out to public comment? Seeing none, Rosie, any raised hands online? Any raised hands in person? Seeing none, I'll close down the public comment for the consent calendar, and I'll entertain a motion.
I'll move to approve the consent agenda.
Can I get a second? Second.
Thank you. Directors Cox and Gallagher. I'll take roll on this item. Director Cox?
Yes.
Director Gallagher?
Yes. Yes.
Director Pimentel?
Yes.
And Chair Hughes?
Yes. Okay, moving on to item number three. It's our discussion item. It's a medical executive committee's report approval for May 2025. It's the medical executive committee's report that we received in closed session. Are there any questions for staff about this before I open it up to public comment? Okay, seeing none, I'll open up the public comment. Anyone online wishing to speak on this item? Anybody in person wishing to speak on the item? Seeing none, I'll close down the public comment and I will entertain a motion for item number 3.
Move approval.
Second.
Thank you, Directors Gallagher and Cox, I'll take a roll on this item. Director Cox?
Yes.
Director Gallagher?
Yeah.
Director Pinto?
Yes.
Director Davis?
Yes. Okay, moving on to item number 4. It's the Chief Executive Officer report. Steve, are you going to be able to present remotely today?
Yeah, that's the plan. I'm going to try to share my screen and present my slide deck. So give me 1 second to see if I can figure that out.
Students seated in edit mode. Perfect.
How about now?
And presentation mode, very well.
Presentation mode, and you can hear me?
Good? Yep.
All right. Let's launch into it. So I've got a few items to go over today. I want to show you the latest dashboard as we do every month. We've got high-level results for our culture of safety survey. So I'll show you those. We've got some good news on the primary care growth front. I'm going to talk a little bit about a little preview of board policies and procedures manual, and then give some legislative updates. So on the dashboard, we are still better than baseline and just shy of target on our likelihood to recommend the hospital. We're still sitting at about the 60th or between the 60th and 65th percentile nationally, which is great. This is just about 0.2 of a percentage point lower than it was last month, but still very strong. And our safety priority index, this is probably our strongest performing dashboard metric so far this year. We're at 10 on a rolling 12 months, and we've had, I think as of today, 4 year-to-date hospital-acquired conditions compared to the 15 we had last year and the 30 plus that we had the year before. So continued great movement on our safety priority index for our patients. Caregiver safety continues to be red, so we have had more injuries to employees and providers so far this year than we did at this point last year. A lot of that is on the workplace violence side, and we have a wonderful workplace violence committee that's been stood up. Margaret in human resources and Phyllis nursing leadership, along with a lot of the frontline staff working on how can we keep our employees and each other safe from patients who may be lashing out either for medical or behavioral challenges that they're dealing with. So that's been a big portion of the increase in injuries this year. So we're going to try to make a huge dent in that and reverse that in the second half of the year. Staff retention, we continue to be better than our target for the year, and right in between target and best practice. So 85% is our retention rate for a rolling 12 months. And I mentioned the SCORE survey. So on the safety climate domain in particular, we did not hit our baseline or our target. We were at 25% of the responses were positive on the safety climate domain questions, and I'll talk a little bit more about that in a couple minutes. For patients served, it continues to be a mixed bag. We're outpatient, we are outpacing our target and our budget. And for inpatient admissions and observation admissions, we are behind our budget and also even a little bit behind, about a percentage point behind where we were last year in admissions. So few percentage points above our budgeted target for outpatient, but trailing on inpatient admissions. And Julie will have a number of detailed drill downs into those when she does the finance report. And cash flow from operations continues to be behind budget as well. 4.7 million behind as a negative, and so about 4.6 million, 4.5 million behind budgeted target for the first 4 months of the year. And Julie will get into that quite a bit more. And I'm going to talk a little bit about some of the financial things that we see ahead with legislative updates, which are also not trending in the right direction. But that's where we are. That's where we are right now on our dashboard. For the SCORE survey, so this is our safety communications, operational risk, resiliency and burnout and engagement survey that Beta does for us. We had 361 respondents, which was right about what we had last year. I think we had 370 last year. So pretty similar to the response rate that we had last year. There are two different sort of buckets of domains of the questions. So I got two slides with results. So the first one is this one, and you can see the culture domains, about half getting better and half getting worse from the survey that we did in March of 2024. So you can see the red numbers show where we went down from the previous year, and the green numbers where we went up from the previous year. And then the second bucket of domains is the engagement domains. And with one exception of one that stayed flat, the rest of them actually went down here. So we've clearly got a lot of work to do here. We know that there was a lot going on during March when this survey was taken, but we don't want to make excuses. We want to make action plans that are going to help improve where we are and where our staff are feeling in terms of their engagement and their culture of safety. So we will be writing hospital-wide and departmental action plans to address the opportunities for improvement that we have in this survey. We're going to try to do 1 or 2 pulse surveys specifically on that safety climate domain that's on the dashboard. So we have the exact wording of the questions from the survey, and we can send those out to staff probably in a couple months, and then maybe a few months after that before the next survey comes out, so that we can kind of see how our action plans are making an impact, and if they are. We also are planning for Just Culture implementation with Beta Heart. They have, as part of the package that we have with them, they will come and do training with our leaders and our physician leaders and have an online training for staff. And so we've got a lot of people wearing a lot of different hats right now, but as we get into the second half of the year, we plan to be able to make this a priority so that we can train everybody. And really, Just Culture at a very high level is easy on the people, hard on the process, understanding that human beings make mistakes sometimes, and that when mistakes are made, we should learn from them, and we should encourage people and reward people for bringing those mistakes forward and those errors or those near misses forward, and rewarding that behavior so that we can make change to the process and make that process better so that it's less likely that there's an error the next time somebody comes in contact with that process. So that's really what Just Culture is all about. And there's an algorithm for how you deal with, okay, something didn't go according to plan. What kinds of questions do we ask, and how do we move forward so that it's not kind of the old school healthcare way of like, whose fault was this? We have to get away from that, and we have to get towards this more just culture of safety. So along the lines of the next steps, the report that we do get back from the SCORE survey is very, very detailed, and it has a number of pages like the one that you see on the right here, where it has suggested action plans. So these are really nice starting points for us as senior leaders and for department managers and directors to have a starting point of what they might work on in terms of suggested action plans. Don't have to use those. They're pretty broad and general, so we certainly would want to take any of those that we looked at and make them specific to our units and our hospital and our services, but they're nice starting points to help us with really looking at what some best practices are in those particular areas where we have opportunities for improvement. Moving on from that, we do have some really good news here. So as you'll recall, we brought on Dr. Frank Ravago in January as our first primary care physician within Coastal Healthcare. And starting in June, we'll have Shannon Klassen joining us as a family nurse practitioner. So she'll be joining Dr. Ravago's practice, and this will give us another provider to provide a panel for primary care patients, people in our community looking for a primary care practitioner. These will primarily be Medicare and commercially insured individuals, which will further help sort of the referrals to our specialists and our surgeons and our services that we provide here. So we're trying to let the world know that we've got the opportunity for to accept new patients into this primary care practice, because there are definitely people in our community who are commercially insured who are looking for a primary care doctor. So we've got some good opportunities for continuing to grow and expand that. So we're really excited to have Shannon start and join us. And then just one slide on a preview of an item that's coming up later on the agenda. We are in the process, and this is Rosie and me sort of being the primary points of contact, and Allison Violante is our Director of Government and Community Relations as a really great resource for this as well, but developing a policy and procedure manual for our board and for our district. This is something that's pretty overdue. We've kind of created policies ad hoc as they've been needed, but we really need to just build the policy and procedure manual from the ground up. And so we're doing that. So we've got some templates and best practices. And the goal will be to bring, a couple or a few to every meeting for approval until we get to the point where we've sort of got the whole manual built out. And then we'll have those on a rotating basis for reevaluation and reapproval and renewal every 2 or 3 years, depending on the policy. So looking forward to building out that manual starting tonight. Now, shifting gears and talking about legislation. So I've got a slide on federal and a slide on state, and then a little bit on Medi-Cal locally and impacts here locally. So as you are probably aware, the House did approve their budget bill by one vote on May 22nd. It is a sweeping tax update estimated to add a lot of money to the already very large United States debt. And it's doing that even despite some really significant cuts. So to Medicaid, or Medi-Cal as it's known here, estimated to be $715 billion in cuts. It would implement work requirements starting at the end of next year. It would increase the verification and re-enrollment requirements to twice a year. It would place restrictions on states' provider tax programs, which I'll talk about in a little bit as well. It would exclude non-citizens from the program and recommends penalizing states like California that provide coverage to undocumented persons. It proposes to eliminate all coverage for gender-affirming care. And though it doesn't specify any specific cuts to Medicare in the bill, the Congressional Budget Office does say that in order to meet the goals of the bill, it is going to require cutting Medicare by nearly $500 billion over the 8 years from 27 to 34. So not an insignificant amount on the Medicare side as well. On the state side, the governor's May revise is looking to close the budget gap with about $12 billion in budget actions. Medi-Cal is a big one, and in particular, cuts that are specific to undocumented people, including freezing access for those 19 and older, effective at the beginning of this coming year, instituting $100 per month of premiums for those enrolled, starting at the beginning of 27, removing all access to long-term care and dental, as well as elimination of things like acupuncture, some other services like that, and the reduction of funding for federally qualified health centers, which does not impact us directly, but does impact our partners like Salud para la Gente, where they could be seeing their own cuts to their fee-for-service reimbursement. here in the Pajaro Valley and in Santa Cruz County, a little bit of Medi-Cal population numbers. So there's approximately 40,000 Medi-Cal recipients here inside the boundaries of our district. Over 12,000 of those are children, and over 10,000 of those are potentially subject to those work requirements that were mentioned earlier in the House bill. And in Santa Cruz County, there's about 8,000 undocumented people currently receiving Medi-Cal, and a couple thousand others who are eligible but aren't currently receiving it. I don't have the numbers on how many of those 8,000 are here in the Pajaro Valley. This one is a little bit harder to track because we don't ask, right, about documentation status. Now, so what we've tried to do is estimate the financial impacts to us, to our hospital, of what's going on here. So I started sort of at the national level, where Medicaid covers about 80 million Americans. And the Congressional Budget Office estimates that 7.6 million Americans would lose Medicaid coverage if the House bill passes as written. So again, it's just gone through the House. It hasn't gone to the Senate yet. Senate is probably going to make changes. But if the House bill theoretically were to pass as it is written, the little under 10%, a little over 9% of Americans would lose, who have Medi-Cal now, who have Medicaid now, would lose it. So if we use that 10%, that kind of a little higher level of 10%, that's about 2.8 million a year in net revenue for our hospital. That's based on 2024 numbers, so that can fluctuate from year to year, but that's what that would be for us. So not an insignificant amount given our already lean and slightly negative margins that we already have. Now, that's just the fee-for-service Medi-Cal that we get. So we take care of a patient, we bill Medi-Cal or the Alliance for it, we get paid for it. That only includes that. It doesn't include the hospital quality assurance fees or the QAF revenues that we've talked about a lot. That's on the provider tax side. And so the provider tax programs are being looked at by the federal government, and the House bill did talk about potentially freezing those at current rates or reducing them and looking at no new programs. We're currently in QAF 8, which is already approved. We already know what we're going to get from QAF 8 in 2026. It's going to go up. Nobody that we've talked to thinks that that is at risk, but what happens beyond 26 on the QAF payment side is potentially at risk. The state was looking to increase QAF 9, which would start in 27, would have had a big positive impact for us in our hospital because our Medi-Cal mix is so high. That one is up in the air right now. There's going to be a debate between the state and the federal government about whether whether QAF 9 is a new program or if it's just a continuation of all of the QAFs that we've had. There's going to be a conversation about whether it should be frozen at QAF 8 rates instead of going up, as the state is trying to make it increase for us and other hospitals like ours. The other way that it could be impacted is that if 10% of people or more of people in our community do lose their Medicaid coverage, then the number of Medicaid patients that we're taking care of will commensurately go down, which would decrease and change the calculation for our QAF payment going forward. So even if the program is frozen at current levels, future years of QAF payments could actually be less because we'd theoretically be seeing fewer Medi-Cal patients, even though those patients that were on Medi-Cal are now just uninsured, but that's not part of the calculation for the QAF revenue. So hopefully that made sense. That was kind of a lot. So I'll stop there for questions and then let my colleagues take over from there. I'm going to stop
Any
sharing
questions?
so I can see people a little better. Or I'll keep it up in case you want me to go back to any of the slides.
I was gonna ask that, Steve. Thank you. Dr. Gallagher?
It's not a question, it's a comment. A large percent of people, that 10%, still are gonna have medical needs here. They're just gonna become unreimbursed.
Yeah.
All right, I just wanted to say that.
No, that's right. And I'm working on some much more public, op-ed type writing in the local press about that in particular, because this is, what we're talking about here is the impact on the hospital, the impact on the people with Medi-Cal, but it really impacts everybody, right? Because when all those people who now do not have coverage anymore can't go see a primary care doctor, they just get sick and then they come to the emergency department even sicker, or they come to the emergency department for their primary care. And so emergency department visits go up and they get more costly. And so everybody's wait time in emergency departments goes up. Everybody's private insurance premiums go up because the cost of healthcare has now escalated. So trying to do some more public education on all this and, call your senator.
Any other questions for Steve before we move on to the nursing update? Okay.
So before we do the nursing update, Phyllis, I just do want to echo what Marcus said earlier. Mako, thank you so much for everything. You've been just an amazing partner. I'll just speak for me. I mean, Marcus said some great things about what you said, what you've done for this hospital and this community, but just for me, just welcoming me into this this community that you've been a part of for 3 decades and helping me on board, and all the work that you did through the Measure N campaign and everything else. You're gonna be missed. We're glad you're still in the community, and I've just really appreciated working with you. So thank you for everything.
Thank you, Steve.
Whenever you're ready.
Well, losing my partner in crime here. So just wanted to follow up. Last we spoke, we were heading into hospital weekend, nurses weekend. Just wanted to let everyone know what a wonderful celebration we had and appreciate everybody who was able to support. During that week, we did our palliative care soft launch. And so our palliative care team, it's a physician consult team with nursing and social worker, is launched. And so very happy to say we've had our first referrals and everybody is very excited. So more to come on that. One thing to note during Nurses Week, we had a local deacon from the Catholic Church come and do a blessing of the hands on the nursing units. We have lots of amazing photos and not a dry eye in the house. Nurses were sitting there just crying. It was beautiful. It was really fun. We even got to bless some of our physicians. So it was a really wonderful celebration. Of note, Babs Kingsley has moved on to a new opportunity. So we have an interim ED director. Her name is Michelle Yamasaki. She's the ED manager. And so now she's sitting in this interim director role. And we are sourcing a long-term ED director. So as you know, our ED is a very busy and high volume environment. So we are doing everything we can to support Michelle. Have an awful lot of regulatory activity going on. Been a very successful Joint Commission lab survey. I guess it's been 2 weeks ago now, feels like yesterday. And today and yesterday, we have CDPH in the house. They're going to continue through probably the rest of the week, coming in on a complaint survey and doing a certification of our CT trailer. And so far, all is going well. That's it for me.
Thank you. Any questions before we move on to Matt? Yeah. Thank you.
Tony, just a couple of things to touch on. Our CHP, Lupe, and Coastal Health Partners have 2 agreements out to intensivists for in-person coverage, for call coverage. Doctors Nahn and Ganshorn both received service agreements that they're reviewing and working through. On the facility side, we've been moving along several projects. We had a great meeting today with the architects and the designers for the ED expansion project. And we will be meeting with the greater team next week to review 3 initial design proposals that they put together for the group to review and essentially pick a direction on how we'd like to proceed before we get into the fine tuning of the project. Solar project planning is underway with Met Systems. We talked about that previously. Yesterday, we met with the American Energy Partners. Michelle presented last week on the LED upgrade and conversion project. That will be underway soon. We just need to make our first payment to them, and once products are ordered and delivered, they will begin that project, which will take quite some time making their way through all the buildings. But it's going to be a great savings for us in addition to just better lighting quality overall. That's really it for my report today. Thank you all.
Any questions for Matt or for either of the three presenters before we open up to public comment, please?
Echo on the ED redesign. I assume this goes through everybody. My request is that nurses get to have their fingerprints all over the process.
Yeah,
Thank
we met, April 29th was the initial kickoff meeting, where the greater team put some, comments on the plan that was put together almost a decade ago at this point. And so the design team from that input has come up with 3 potential strategies of design, I guess, that will be presented, and then the greater group will start working from there.
Thank you.
My question is on that too, Matt. Is it like a certain percentage, or do we get to a certain stage where it comes in for, say, like a presentation to the board or for the public to see, like, okay, this is the direction we're heading in? Just kind of trying to understand what the decision points are for us, for the board on the ED redesign, and how we can help get the word out to the community.
Yeah, so yeah, definitely. We really, so that 2016 design, things change, obviously,
Right, yeah.
for our organization as well. So that one, for the most part, really is scrapped. Some of the concepts are being applied to these other 3 proposals. Once the challenge is going to be, as you can imagine, 35,000 patients a year that are going to continue to need to be seen throughout several years of this expansion project. So phasing really becomes important. And so there was a lot of discussion about that today. And if you were building a new facility that wasn't occupied, you have more flexibility in design. There's going to be some concessions and considerations made for keeping operations going. So once the team picks the direction that we want to go, the 3 designs are similar but very different in approach. Then that will be presented to the board, and I think there's going to be a lot of input, as you can imagine.
Yeah,
From a lot of partners. So
that's great.
we've allocated enough time for this design, so it's not something that we're rushing into. We're going to be taking our time and making sure that it's for this time of day, that it's the right design for the organization community.
Fantastic. Yeah, I love, and I know that we've had discussions about this, but just the entrance of the front of the hospital, making it feel a little bit more homey, like we have like a you have like a sense of place when you walk into Watsonville Community Hospital, what we're about, the community's about, that sort of stuff. And interweaving what makes Watsonville special into an ER department. And a lot of folks go in there and are in a panic or in a crisis, and any way that we could make that welcoming, right? And have it be soothing to any extent possible. Think about like involving our community if possible, helping commission a mural or whatever that might be. And I know that, June with the foundation has been looking towards that, how do we implement art into the hospital? So I like conversation probably for 2-3 years down the road, when you get to that, of like, okay, the shovels are in the ground and now we can start thinking about the bells and whistles if we get to that point. But I'd like to, to be able to host some of those community listening sessions on that.
That'll come well before shovels are in the ground.
Okay, good.
So there are some challenges, meeting regulatory compliance, obviously, and safety and security doesn't always lend itself to a warm, welcoming environment with metal detectors and other things, but all those things considered, right? We know the vibe of what we're trying to achieve with the community, and that's definitely a consideration.
Thank you. Any other
I
questions, please?
have a follow-up question. In the 3 very rough drafts of the design, are the 2 overflow rooms in the ICU maintained?
Yes, there's 2 different versions of that. 2 of the designs, they all retain space in that overflow.
Good enough.
One of the designs retains both double rooms, because they are double rooms. The other designs maintain one of those double rooms. So those are all things that will be discussed. As we
Okay,
go.
thanks.
Definitely, that's a big consideration.
Thank you. Any other questions before I open up to public comment? Or is it? No? Okay. Thank you for the presentations. I'll open up to public comment. Anyone online? Rosie, and you raised hands online, wish to speak on this item? Okay, seeing no hands online, I'll go to people in the audience. Seeing no hands here, I'll just thank you all for your reports. And Julie, we'll move on to item number 5. It's the Chief Financial Officer monthly financial performance update. Whenever you're ready to go.
Since Rosie has me at. as Steve warned you, the numbers are not particularly pretty, but we will talk about what's going on there. So, first of all, for the month, we lost $860,000 for the month, and, primarily, we've had very soft volume, so a lot of it does continue to come out of the operating revenue. You can see for the month, we were 2.4 million below budget. Some of the things that I also like to look at during that period, especially when volumes are soft, is how well are we able to flex and be efficient, because there's only so far we can go there and still meet staffing ratios and requirements. So you look at labor and you say, well, it looks like you're doing okay, you're $673,000 favorable. I actually do a little analysis to say, given, kind of what we would have done on a per unit of service, a per patient day basis, we're actually unfavorable in labor by about $161,000. And, some of that is the cost of efficiency when you're at lower volumes. Looked at supplies in the same manner, and we're actually doing okay on looking at supply expense for adjusted patient day. And the favorable variance that we see here of about 369,000 is kind of right in line with where it should be. The one other thing I wanted to point out on this slide is we've got a new line item down below leases there, where it says non-operating income. And in future months, we're going to break this down a little bit further, because this is some of the bond reporting that we now need to do, but it's a little bit still buried in there. The non-operating income is actually, we earn income of the investment income on the bond proceeds that we have left after the purchase. But then we also have the county collecting tax revenues based on the bond proposition. And so we have to accrue basically for that payment that's going to go out to the bond holders. And they're basically offsetting. They don't look like it here because there's some other things in the lease line that offset that. And that's why we're going to extract it out and kind of separate it for future reporting purposes. So you are going to start to see a little bit more detail that's kind of bond specific versus other. Next slide. So on a year-to-date basis, we're $5.1 million net loss, and significantly below our budgeted EBITDA for the year. And again, here, I've been doing some analysis, really trying to tease out what is volume related versus what is we haven't been able to implement initiatives, or they're still in progress, scheduled to come later in the year. And I'll be honest with you that we would have liked to have done probably a better job at spreading some of the initiatives to later in the year. That was our goal before the cyber attack. And after the cyber attack, since our budgets were one of the last things we could kind of get our hands on, we scrambled, and our budget is spread much more evenly than we really anticipate. But we are at the same time behind in some of the initiatives. So when I look at the volumes of the revenue initiatives that produce volume, I'll say there's probably about a $3.2 million impact there in the numbers you see. And then just when you look at it more from, but are we collecting enough? What's our service mix look like compared to maybe how we budgeted? Then there's another $3.4 million impact. And the remainder of that almost $8.3 million deficit year to date is around Block 9. And the fact that we knew it wasn't going to be implemented, early this year, we're hoping it'll be approved in some format and survive everything that Steve just talked about, by the end of the year. But we did do some projections, back in November and early December about what we thought Block 9 might produce for us, and we tried to be pretty conservative, but there are a few dollars in there. The labor efficiency, similar to what I spoke of on the month today, For year to date, we're about 558,000 unfavorable. And again, the supply expense seems to be pretty much on par with what we would expect. I think we all still suspect that there are supply opportunities. I mean, we've had increasing supply costs over the years, so we budgeted more supply expense with the anticipation that we have opportunities that we've yet to identify to actually reduce supply expenses, because the growth over the last, 2 to 3 years has been tremendously high. And we just know from a little bit of work that we had started to do with Vizient, our group purchasing organization, and some of the data they were presenting, that we certainly had opportunities. So that is work ahead of us. Next slide. So on the month-to-date stats, as I mentioned, admissions have been low all year, and they were, down about 45 admissions this month from what we had budgeted. We had budgeted for some increased pediatric volume, and we kind of put a pause on where we thought we were going there to make sure that we're kind of operationally stable and ready to do something like that, and to even make sure that it makes sense, because sometimes more of the analysis that goes into the peds population that comes into the emergency room, the peds population that gets transferred out, that would need to continue to get transferred out because of the level of care we could provide. It raised a number of questions for us to just say, let's make sure we're doing the right thing before we do it, or we adjust that. So that will create some budget variance for us, and we're looking for other ways to offset some of that volume. And then we have been down on the adult volume as well. It also translated into fewer patient days, because we had a pretty low length of stay this month at 3.07. And, we budget at 3.37, and, kind of over the course of the year, run around 3.5. So 3.07, less length of stay translates to less days. We did see a higher case mix this month, and so we did a little bit of looking at what was different about the case mix this month. And case mix is measured by a relative weight that each DRG receives. And so we looked at some of the case mixes that were greater than 2.3, because if ours is averages around 1.4.5 to 1.5. Being up at 2.3 is significantly higher. We found 11 cases kind of comparing month over month, to kind of explain the increase over where we were in prior months. We also saw that we had a number of baby cases, both premature babies and full-term deliveries, that had some what are qualified in the DRGs as major or significant problems. And we've had a number of cases there, and you can even see that we had a higher number of OB/GYN kind of surgical cases during the month. Next slide. So on a year-to-date basis, I wanted to kind of comment, because Steve showed some notes on the inpatient admissions plus observations from his dashboard, and kind of where we were there. And his numbers present a little differently, because he's including the observation numbers, where in this particular slide, we're only showing the admissions. So it's been interesting this month, because everything I've been telling you about soft admissions and being below year-to-date budget, we actually have 16 more actual inpatient admissions than we did at this time last year through the first 4 months. But when you look at the obs, which I don't have that number on here, so I quickly went and grabbed it, our observation cases are down like 18% year over year. And so when you combine them, it is true that the admissions plus observations are slightly below the baseline of where we were at this time last year. That's not necessarily a bad thing, as long as we continue the work we do to make sure that we're getting the appropriate designation for medical necessity, because that really drives whether we're going to be reimbursed or not. And it also, observation cases if they're in-house too long, you hit a point where you're not getting reimbursed, you're still expending energy and costs and things to care for them, but there's no further reimbursement. So it's not necessarily a bad thing to see the observation numbers decreasing. Oh, not quite ready for you. Fast fingers. The one thing I wanted to mention, inpatient surgeries have been up, and I'll talk a little bit more about that in the future slide. The outpatient unfavorability that you see here on outpatient surgeries is almost all the delayed cath lab. Just from the way we had budgeted, how many cath lab procedures we thought we would be doing. And again, some of it may be a little bit, unfortunately, too front-loaded, because we do expect to ramp up, and our budget wasn't necessarily spread that way. But we will get into the other, so kind of what we're seeing in the other slide. Next slide. So here's our typical admission slide. Really, it shows fairly flat, maybe a slight upward trend. And probably very interesting to see that April 25 is very similar to April 24. Difference of free admissions, 265 this April, 268 last April. Next slide. Here's the inpatient acuity or the case mix, and you can see at the left-hand side, so back in May and July of 24, we had some pretty high case mix, which again, probably, I didn't go back and look, but that usually says a few cases with a very high relative weight can shift it to that much. So if I kind of threw those 2 months out and really started at August and looked August to April of 25, you would see there's actually, we are starting to kind of trend upward. And I think that, there's a number of things that contribute to that. One probably most significantly is having the services that we need here and the physician coverages and call coverages and specialists to see patients that we might have previously transferred out of here. And then that somewhat generates a kind of, we can do it, we can keep more patients here. And the other portion is probably, we do a lot of work around physician documentation to support the DRG that we can actually code the account to. And so with better improved physician documentation and making sure you capture complications and comorbidities, that also can drive up the case mix. And we have a lot of focus on that from the HIM side. Average daily census, it really has, been going down slightly, and we've certainly felt that over the last number of months. And this was a very low census month, again, because of the lower length of stay. Next slide. On the outpatient and ED visits, ER visits were down this month. Outpatients were going up, but even with ER visits being down this month, we still averaged 92 patients a day, so it's still pretty busy over there. Next slide. Deliveries, last month we had dropped a little bit and bounced back this month, so I'm still maintaining that we've got kind of a nice upward trend that we've been seeing since about June of last year. With March just being a little bit lower. Just a few of those February babies have been born in March, but even now. Next slide. Want to go?
Yeah, it's gonna go all at once.
Okay. Well, you're right. Total surgery, exactly. So, here we had 62 inpatient surgeries and 115 on the outpatient side. I kind of looked at what would have been some of the largest year-over-year increases from where we were at this time last year, and it's been in GI, OBGYN on the inpatient side, and ENT on the outpatient side. And then also looking at where have we seen some of the largest decreases. On the inpatient side, it's been ortho and podiatry. And on the outpatient side, it's been general surgery and ortho. So We have had some transition in, the ortho docs. We also are, I think, having a little bit in the general surgery coming up. So, we'll just kind of continue to watch where the movement is. So on the inpatient admissions, kind of took a little closer dive because there wasn't anything exciting to report about our, commercial mix in April actually being less at 12.8%. But I went back and I said, okay, how's it look kind of year to date as I compare to last April? Because, sometimes 1 month doesn't tell the whole story. And so I was, pleasantly able to report that year over year for the first 4 months, we're up 1.5%. So we've had 20 more commercial admissions through 4 months this year than we had last year. And that we've seen some of the shift. The Medicare mix is down about 14 admissions. The managed Medi-Cal, which is primarily the Alliance, is up 24 admissions, and the self-pay is down about 13. So as Steve was doing his talk, I did kind of a quick other look to see, well, how many actual Medi-Cal and managed Medi-Cal admissions have we had year to date? We've had 535 year to date, which represents about 48% of our total admissions. So, when we talk about our population being heavily Medi-Cal and managed Medi-Cal, and most of those are on the managed Medi-Cal side, it's significantly weighted to the managed Medi-Cal. Next slide. Okay, so on the outpatient side, commercial, it was a good month. Commercial, we were at 24.4%. It's year to date, it's up about 315 visits over last year. And April had a nice uptick in visits as well. The Medicare visits are up about 107 compared to last year. Managed Medi-Cal 486, and self-pay visits were actually down by 208. And one of the things to realize about self-pay is with every self-pay patient that comes in, we try to find them eligibility in a program, whether it be a medical program or some other services, so that we can convert as many of those off the self-pay roles as possible. And so I also looked at what was our, total outpatient visits for Medi-Cal and managed Medi-Cal year to date is 12,426. And that represents 51% of our total visits. But interestingly enough, when you look at just the ED, Medi-Cal and managed Medi-Cal only represent about 33% of our ED visits. So, okay, let me pause a minute because I'm going to switch over to cash, but see if there was just any questions on the general financials.
Any questions for Julie about case mix or any of the information presented so far? Yes.
All right. So just a couple last slides to talk about cash updates. Here's my dynamic cash forecast. And it's dynamic because every day when I update what cash came in, if it's been a little better than I projected, the numbers go up. And if it's been a little worse than I projected, they go down. So even times I think, oh, it looks pretty good today. And the next day is a little lower day. And part of that is because a lot of the forecasting really depends on looking at like a rolling, 4 weeks or 4 pay periods to predict the future. So this is what it looked like as of yesterday. And, really what I just want to point out is that, we start somewhere, we kind of inch our way down. Sometimes we get an advance or something, or have something large coming in. But how reliant we are on these QAF payments. And so, the first place where you see a QAF payment in October of 25, we've already done some advance against that QAF payment. And I know that big QAF payment has to go make it to the next big QAF payment, which doesn't come until March. And so often when those QAF payment comes in, it's not like I do a whole bunch of AP catch up. I do more planning to make that budget last as long as I can make it. Now, we have been, working to find other ways to get some funds, so through intergovernmental transfers, something that I'll be presenting to the district tonight is one of the agreements that we're looking at. And that is the one that says, we can get into another program, we can, send some cash up to the state that sends up to the feds to get more money to send us back. So what you'll learn is that, a $600,000 investment now in October, November could bring $1.3 million in February. So that's where I show a little IGT payment in February to kind of help us get to March. Then, we get up to March and, you can see it kind of significantly drops because I make some AP payments, but I also make, start to make a payment to get into the next IGT program that we're trying to get into. And that payment actually comes up in about April. So I have to, plan for those sorts of things. So that's why, it kind of gets so spiky because I can't pay everything off because I'm trying to make it last. We get a quick bump, but then I spend it pretty quickly until we get the next big bump. And this graph right now is just going out till December of 26, and I guarantee if you ask me a month from now, it'll have some of the similar spikes, but it'll look different. Next slide. Here's our accounts payable aging. This has really been, kind of our Achilles heel, because, besides trying to make the money last, we still have a lot of work to do to make sure that we can kind of live within our means. And there's a lot of work that goes in and will continue to go in on the cash collection side, but we have work that we're also working on the spending side and trying to control spend, and I'm going to talk about that in the next slide. So really what this is showing you is that, for most of the period here, this is February through May, we average, more than 65 to, between 65 and 70% of our AP being more than 30 days old. So it's definitely a struggle for us. And as a result, we do payment plans, we do a lot of, creative financing with our creative negotiation with our vendors. Next slide. So my last slide is to say, just tell me some of the things you're doing about all of this. And this is not everything, but it's kind of the major themes. Productivity, we talked about, with the lower volumes, how efficient can we be? What do we do when the volumes really drop off? Nursing units have always kind of lived by staffing grids. And when you have this many patients, this is kind of what the lineup of staff looks like. Macto's been working within his area to set something up similar, so that they kind of know when, okay, it's really low, you really gotta flex some hours off. We're also gonna embark on this even in the support departments, where at some points, even though the work may kind of feel like it's just the same work, we've got to get more nimble and flex off some hours there so that we can afford to stay, keep going. Revenue capture, there's a team working on improving charge capture, identifying where we might be missing charges, just making sure that we're reconciling our revenue and our usage every day in a kind of standard format, so that we can identify where we might have opportunities. Our discharge not final bill is kind of like the last stop before that claim can go out to the payers. So I know if it's still sitting in discharge not final bill, I'm not gonna get paid on it. It's gotta get out of that bucket. We tend to average 5 to 6 days from the point the patient discharges till the claim's out of DNFB. But, the cyber attack, at one point, when we were in that early stages catch-up mode, we were up to 20 days. So it's been a haul to get back down. We've been averaging over the last few weeks or so in the 8 to 8.5 range, because it'll fluctuate a little bit after a weekend. So we know we still got some significant work there, which just involves making sure the things that are kind of holding it up are getting attended to. And that could be everything from charge capture to physician documentation to just getting the account coded. Doing work to look at, aged dollars in the, accounts receivable that probably should have been collected and paid on. And, you know, why haven't they been, and what's hanging them up from that? So I do a lot of work with our, billing and collection agency, Guidehouse. Physician documentation, again, just, it helps both with timeliness, but also, you know, supporting the highest reimbursement that we can, you know, possibly earn by making sure it's complete, timely, and capturing all the patient conditions. Getting our new initiatives, implemented, you know, there's been a lot of contract work going on. Got the radiology group coming in, got a lot of work on the hospitalist group, intensivists, anesthesia. So getting all those, you know, as prime as we can get them, getting the cath lab open. And then, you know, later in the year, some of the CT and MRI, when we're able to get those new pieces of equipment in place, they will be more efficient, they will help us generate more volume. But that is, you know, more towards fourth quarter. And then there's various pay practices that we identify, and this is not only just can we be better at overtime or premium pays, but also are we paying appropriately to what the contracts say? Is there, you know, there's a lot of codes that people have to put in and approve and review to pay a paycheck. And so there's a team that's working on identifying that we're doing things correctly with the pay practices. And then, as always, we have AP payment plans, vendor relation activities. We've got a weekly AP disbursement review meeting, trying to put proper decision-making criteria in place, so that we can just keep everything moving. So it's a lot of work. It requires a lot of people because we want the inputs of everybody, because we know these things impact everybody. So we can't just do it in a vacuum. So with that is my report, and I will take any questions.
Any questions for Julie about other parts of the report?
I'll just share that Dr. Gallagher and myself at our life finance committee spent about an hour going through these in detail, and appreciate the time that Julie, your patients and your staff. The questions, these are rough times, no doubt. I mean, our liabilities to our vendors is 5 times greater than our cash balance. And that's not a great place. We do have a strong accounts receivable position, so that's encouraging, but we're still getting through it. I appreciate the transparency and the candor. You've not held any punches and being very honest with the situation, so I just appreciate that.
Any other questions for Julie? Before we go on? I do have just a more like big picture kind of question, Julie, and maybe Steve can help with this as well. I did a couple of interviews just with local press about, I think, exactly what Steve was talking about, whether it's Medicaid or Medi-Cal cuts happening at the state and federal levels. And the question I continue to get is, how is this going to impact services whenever these sort of cuts might be in effect? And I think, you know, it's not a company line or a canned answer or anything like that. It's the honest answer that I'm giving is right now I can't really predict how it's going to impact services, staffing levels, all that sort of stuff. But we know that if some sort of major cuts are proportioned out over the course of however X amount of years, that they will be impacted. And I guess my kind of larger picture question is, what sort of practices or strategies are we undertaking right now to kind of insulate ourselves for those things, against those things, I guess?
Well, you know, it's hard to strategize against, there's a lot of unknowns, as
Right.
Steve pointed out, and as you pointed out, and there, you know, a lot of things that we hope don't come to complete fruition, because we suspect that if people lose their coverage, the care they're gonna get from us is they're gonna come to our emergency room uninsured,
Right.
with probably larger health problems because they haven't been able to keep up on their regular health care. So that doesn't bode well. I think the strategies that you take to try to, you know, foresee the future and protect yourself are the same strategies we're trying to take to be financially stable. We've got to live within our means. We've got to optimize every opportunity we have to be efficient, to save money, to grow services that make sense, to, you know, make sure we're collecting all of our cash. And so we're already doing those and, you know, every day almost looking for where can we double down on
Right.
some of those, because, you know, we already have that kind of stretch target to get to where we want to be versus where we are. So I think, you know, it's more of that. You know, the thing I probably hope for the most is that a lot of this gets, you know, overturned or lessened, because I do worry about the impact it could have on the future co-op programs. And that since they do kind of, they run in arrears, but they directly correlate to Medi-Cal patient days and the Medi-Cal population they serve.
Yeah, I think even before, everything that happened last November and kind of putting us in the position that we're in right now, I think we knew, like, as a board, as a team, clearing the next hurdle was getting Measure N approved and then implementing some of those projects and then seeing the impact that that would have, and then saying, okay, we've cleared the next hurdle, so how do we continue to run the race, right, that we've been running? And so, yeah, I echo what Marcus was saying, and I know it's not a question, it's more of a comment now, but just, really difficult times, especially from cyber attack all the way up until probably mid-April. That's been really hard operationally, and everything, some things come out of our control, but team and the staff, just thank you for your work for, as Marcus said, not pulling any bunches for the board, and, you know, for the people who are paying attention out in the public, just having a good understanding of where we're at, the challenges that we're facing, you know, kind of in the position that we're in right now. And I know that just looking at the dynamic kind of cash trend or the forecast, it looks like we're gonna go up a little bit, and the through line on the back end of that looks like we're making incremental improvements, but still a long way to go. I mean, when we started, I believe, $6-7 million cash on hand. Is that right? When the hospital started, so still challenged, still challenged. Rosie, any other questions or comments from the board?
Just a comment of maybe foolish optimism, right? From the state's perspective, what the governor didn't do in the May revise, more importantly, what he did do is a couple things. He fully funded the state's Medi-Cal costs. The state had a deficit in Medi-Cal. And so that's a sign of fully funding their Medi-Cal commitments. He could have proposed more reductions to right size, because Medi-Cal had a massive deficit. So he funded Medi-Cal. And while proposing to reduce what I'll call full scope Medi-Cal for undocumented, there's been no discussion of the emergency Medi-Cal provisions that applies to everybody who doesn't fall under full scope, which generally includes doctor provided, doctor authorized emergency rooms of pregnancy. So, I mean, there's a little bit of, I don't want to say hope, but like, you know, the governor has clearly signaled the priority in keeping a base level of care for everybody, regardless of status. Well, it's not good what was proposed. It was, again, those two things of the commitment to full funding Medi-Cal instead of making other cuts, and then not even discussing their safety net Medi-Cal. That's always been around for most of us, been around for a while.
Right. Yeah, I think to that, you know, I'm sure we're also getting the same sort of advice, and Steve is in the same sort of conversations as I am as well on the day-to-day. It's just, I think, it was encouraging what the governor did for, the cuts that, could have been made that were possibly in the discussions, and for what was ended up coming out in the May revise. I think for me, as I look at the forecast into 2026, the second revise that's coming in October, following whatever it is that the Senate and then the president ends up signing is where I'm most concerned, I suppose, is at that time. Because of everything that Julie said, call payments, all those things, so. And any other questions or comments?
I just have to say this, I think I was quoted in the minutes of, it's ludicrous, and I agree with you, though, that federal policy discussion is ludicrous.
Yeah.
It's unfortunately characterizing, coloring everything,
Yes.
so thank you for that.
Rosie, any raised hands online wishing to speak on this item?
On the line.
Okay, anyone public, please?
Good evening, Board. I'm Allison, I'm the Director of Relations here. I just want to underscore something that Chair Nunez just mentioned, which is while I'm agreeing with Director Pimentel that it might look optimistic, the cuts that were proposed, backfill, Medi-Cal, it's not the end of the state budgetary process, and I just want to underscore that because the May revise did not incorporate any of the cuts that are being proposed at the federal level. And therefore, we anticipate there being a special session coming in the fall. Once the federal government finishes their budget, so that's why there's so much uncertainty. This is what we know now, and so I just want to underscore that we do anticipate a special session coming following the federal budgetary process, which will likely include further cuts at the state level. And so we don't know what those will look like, and so I just want to caution us to be overly optimistic and not put up the fight about pushing the state to be the backstop that we need them to be on this issue.
Thank you. Anybody else wishing to speak on this item? Okay, I'll bring it back to the board for any final comments, and if there are none, then we'll move on to item number 6. Okay, Julie, item number 6.
All right. Well, item number 6 is our consolidated audit report for 2024. It's my pleasure to introduce our auditor, Gerald Tucker. He's up on the screen today. He's been here the last couple of years in person, but it's a long drive. He was more than willing to come, and I said, I think we can do it by Zoom this time. So he has been our auditor for the last few years, JWT and Associates, and he's going to walk us through at a high level the 2024 audit. All yours. You might want to let Gerald see him at the
Gerald,
You-
you're on mute.
There, that probably, now you can probably hear me a lot better.
yeah.
Okay, good enough. I had an opportunity to meet with the finance committee yesterday and go over the audit in detail and answer some questions and whatnot. And so now is a chance to present to the board, the full board, and get approval of the audit this year so we can move forward. So let me just preface this. I understand there's at least one person that hasn't gone through an audit report in the past. So I wanted to reiterate the fact that when we go through as auditors and go through the books and the financial records of the hospital, the district, it's not our job to give an opinion on whether or not you had a good year, bad year, made money, lost money, whatever. Basically, an audit is designed for us to give an opinion on, are the numbers accurate, and are they properly reported in accordance with GAAP, generally accepted accounting principles. So we can talk about whether or not, and we can answer questions on whether or not we thought you had a good year, or why is this happening or that's happening or whatever. But understand that really an auditor's job is just to give an opinion so that those who rely on your financial statements know that whatever the results are, the numbers are accurate and they're reported within GAAP. Does that make sense? Does everyone kind of understand that? Okay, good.
Yes.
So you see the audit result, the one page outline there. I'm just going to go through that. If you have any questions, feel free to stop me, ask a question. I'll be happy to answer if I can. And my goal is that when you're done, you're comfortable with the audit and that you're able to vote to accept it. And then we can move on. You've got some covenants that we're right up against that we need to, well, I don't need to, but Julie and her staff need to get out to some users of the audit by the end of the month. So anyway, that's why we're here. Okay, there are 4 things an auditor has to report to the board, and that's those first 4 bullet points. So first and foremost, we have to tell you what kind of opinion you received. You received an unmodified opinion or a clean opinion on both the financial and the governmental audits. To remind you, you have two entities involved in the audit. It's actually a consolidated audit, because the hospital is considered a component unit of the district. I know they're separate entities, but for accounting purposes with a district, if they have a nonprofit hospital, is that the way it's set up here in Watsonville, then they end up being required to be put together as a consolidated financial statement. Anyway, the hospital and the district both get a financial audit, which is your regular audit, and that's that the numbers are accurate and whatnot. But the district also receives what's called a governmental audit, because it is a governmental agency that requires some additional testing and review and work on the internal controls. And basically, it's the government wants to make sure that, or the feds want to make sure that the governmental entity is receiving and using money correctly within government guidelines. And you got clean opinions on both those, the financial audit and the governmental audit. So that was good. Second bullet point, we have to disclose if we come across any material weaknesses or significant deficiencies in the internal controls, or if there's any reportable findings. In all of our testing of transactions, balances, and so on and so forth, we found no material weaknesses, no significant deficiencies, and there were no reportable findings. Reportable findings, those are illegal acts, basically, and regardless of the amount, we have to bring that to the board's attention. And again, nothing like that. So that's good. Another clean bill of health. There were no audit adjustments. There were a couple of late client entries. These are entries that occur after the audit starts, but are still the hospital's. Julie and her staff come up with them. They may talk to us or whatever, but they come up with them and they propose them. And those had to do mostly with finishing up and getting some final information on the bonds, the new bond issuance and the lease accounts, the effect of the lease accounts, and getting that all trued up. And so that was done. We have kind of a quick turnaround typically with this audit. So we try to get started as quick as we can. And there's always a few late client entries in there, but those aren't any red flags or any issues like that. And then lastly, we have to disclose if there's any difficulties encountered with management, any disputes or disagreements on, how how GAAP is applied or how reporting is done, or whether or not they're going to give us information on certain things. Everything we asked for was provided. It was provided quickly. It was provided in a usable form. And we have no complaints or issues at all about the audit. It went quite well. Questions? So those are the four main things. Everyone understands them? Comfortable? Questions?
Any questions from the board? No questions.
Good. Yeah, you guys are easy. So the last thing I want to talk about is some significant accounting issues, just to make sure that you've probably heard this before. Julie does a very good job and a very thorough financial report on a monthly basis to the board. And so I know you've heard this, but I want to make sure, see if there's any other questions, or maybe I give a little bit different insight on it. Make sure that you understand that we looked at this during the audit. So down under significant accounting issues. First off, we already talked about the component unit reporting. This is an audit for the district and the hospital combined. If you look at the main financial statements, those are consolidated statements. If you go back past the notes, you'll see the consolidating statements that shows the district by itself and the hospital by itself if you're interested. So two reporting units, hospital and the district. We did issue a going concern paragraph this year in the report. So it's in the report as a matter of emphasis, and it's in one of the notes. Going concern, quite simply, is if there's a concern, a concern that if certain things don't happen, the entity we're auditing may not make it to the next year, may make it a full year, then we'll put that in. There's different levels of going concern. Ours is just an emphasis. In other words, cash is a little tight. There's some issues and whatnot, and and so on and so forth. So it's in there, but it's not to the level where it's going to affect the opinion, turn it into a modified opinion, start changing the accounting for basically just distressed sale type accounting and so on and so forth. None of that. But it is in there, and if you see that, I want to make sure you understand that. We look at that we take that serious. We look at it from a lot of different ways. We look at the cash on hand, we look at the borrowing availability, we look at where revenue's going, where your loss, are your losses coming down, what's the budget look like, and so on and so forth. So we look at a lot of the things that Julie just touched on in her presentation. And so we're hoping that the hospital and the district kind of be out of the woods at the end of this next year. And we're hoping this will be the last year that we have that. Kind of everything kind of points that direction, but you got to keep your you got to keep your volumes up and other things. And sometimes with volumes, it just is what it is. But you're doing all the right things to move forward and to kind of get out of that going concern type situation. You guys already discussed that, so that's just making sure you know that we look at that as well. 2024 general bond, the general obligation bonds, those were issued, they were booked, they are on your books now. You have that debt, $53,350,000 in debt. General obligation bonds are a good way for district hospitals to districts and hospitals to finance expansion or purchase or whatever. This debt was basically 40 million of it was used to purchase the hospital and the facilities and the land. So that's good. You've got another 13, 14 million sitting around. That's for other projects that were identified in the bond issuance. So what happens going forward, the county will, through the property tax bills, the county will bill all those in the district for this. The money will come into the county. The county kind of acts like an escrow account for you guys. The county receives the money. The county makes the payments on the bond, both the principal and interest payments as required. As they make those payments, the hospital recognizes district tax revenue. And to the extent that they've made those interest and or principal payments. And so you'll start seeing district tax revenue down below and other non-operating revenue going forward. And so you get the benefit of the cash. Yes, the debt's on your books, but bottom line is you're not on the hook to pay for it. The cash flow to pay for it is coming through your annual property tax payments. And so that kind of just ties right in with the purchase of the hospital. So you've got the debt booked, you've got the new hospital, well, not new, but you've got the hospital now is on the books of the district. You got you're depreciating it now. You're the owner. We've removed you had an operating lease right of use asset on the books before. That's been removed. The operating lease liability, that's gone. No more leases because you own it now. And so that whole transaction was pretty technical. We walked through it, reviewed it, and went over it with Julie and her staff earlier in the year as the transaction was actually unfolding, and got it all booked as accurate as possible. Then got some final information from the county and other places to true it up at the end. But that has all been booked. So you guys are now the proud owners of a hospital. Good. And so what's going to happen financially is you don't have the lease expense anymore, or any of the interest or imputed interest or whatever that was all done for that lease, for those leases, but you now have the interest expense for the bonds, you have the principal payments, you have the depreciation for the assets. What's going to hit your P&L is going to be the depreciation and the interest. I really haven't looked at it. Maybe Julie has, but I'm not sure if that's a pickup or a loss compared to the lease payments, or maybe it's just break even. But no more. The leases should drop significantly, but it'll be replaced with interest and depreciation. But the good news is depreciation is a non-cash expense. So yeah, it hits the bottom line, but it's not coming out of your pocket, at least not now. And the interest is being paid by your district members. So yes, it's an expense, but it's not an expense that you have to worry about not trying to cash flow. Does that make sense? Put everyone to sleep?
No, we're here.
You know, we accountants and auditors, we love this stuff. I could go on all night long. I realize, not everybody thinks accounting's the greatest thing ever, but
I think you said the
anyway.
exact same thing last year. So,
There you go.
Yeah. I just want to make sure, I understand, so I try not to talk too much, but I want to make sure you understand, make sure we're looking at these and make sure, if something, kind of sits or whatever, or, kind of hits you, I want to make sure if you have a question or you want me to try to explain it better than I can, but if not, we're good, you know. Audit went well and audit financials, I'd love to see a better bottom line. But I certainly, from what we've reviewed since the beginning of this year and the discussions we've had with Julie and her staff, I certainly believe you're doing what you can and you're moving in the right direction.
I'll just comments. Thank you, Gerald. Appreciate that. And I know you bring other experiences and insights from other clients and around California and the country to our staff. So I appreciate that. And I'm still encouraged by this Matco, and our team and this board and this community came together, saved the hospital, created a long-term financial plan to turn it around, and we're progressing down that plan. So I appreciate your comments, your acknowledgement of that in the audit itself. So thank you.
Okay.
any other questions before I open up to public comment or anything else that staff wanted to add to the report? Please, Joe.
Gerald, you mentioned that there are other levels of going concern. Could you describe them briefly?
I mean, as cash gets tighter, maybe you're losing doctors. There's just a number of other factors that can impact a hospital, and it just looks so bleak. We look at your plans that are unrealistic. We look at your, pie in the sky projections, which are unrealistic, and we just say, hey, you're not going to make it a year. Unless someone steps in with X number of dollars or you find some other financing or whatever, you're just not going to make it. You're going to barely get past the next couple of payrolls or whatever. Then that impacts the financial statements, because certain things have to be accounted for differently, and you end up with what's called a modified opinion, because that's going to bring it to the attention of the users that, hey, it's not just that they're having struggles, they're 1 foot in the grave. Does that make sense?
It does. Let me just double clarify that we're not in that situation.
No. You're standing a few feet away from the grave.
Thank you for that.
And walking away. You're walking in the right direction. No, I'm just joking.
Accountant's humor, by the way.
Yeah.
It's not
Accountants
under-
have never been accused of having great senses of humor.
It was pretty good.
Thank you.
Any other questions before I open up to public comment? No? Okay, thank you, Gerald, for the presentation.
Yes.
Any raised hands online wishing to speak, any people online, I should say, wishing to speak on this item?
Don't get the line.
Okay, anybody in person? Okay, seeing no raised hands, I'll close down the public comment and bring it back to the board for discussion and appropriate motion.
I'll move staff's recommendation to approve the consolidated audit report for 2024 as recommended.
Second.
The town calendar, the big role in the item. Right, Director Cox? Yes. Director Gallagher?
Yes.
Director Paul?
Yes.
Attorney.
Yes. Okay, thank you. That brings us to the end of the Watsonville Community Hospital Board meeting.